Hello, I'm Joo Teoh, obstetrician, gynecologist, and fertility specialist in Perth. Now, after a few videos on obstetric care, this is my first video on fertility. Now, today I'm going to talk about a hot topic, which is on IVF success rates and league tables. Yes, it is one of the most commonly asked questions. I think it's fair because before we embark on any fertility treatment, well, IVF more commonly, we would want to know what is the likelihood of having a healthy baby before we choose a center or before we invest our time, money, and effort. Now, the term we use to define success rate, they're mainly used for scientific research and not in our usual daily conversation. Certainly, if you are, you've gone through IVF or fertility treatment, it may be very rehearsed or familiar with those terms. But for our usual, if for people who have not gone through the treatment itself, then sometimes it is hard to understand. But today I'll try my best to explain. So firstly, what we are looking at when we talk about success rate, there are different phases of positivity, or when you have a success up to a certain level. So the first step is called biochemical pregnancy. So for example, after fertility treatment, you do a home pregnancy test, or you go to a fertility center to measure your hormones, which is HCG, the pregnancy hormone. It is up to a certain level, then you might say, look, yay, it's positive, it's a biochemical positive pregnancy. So different centers may use, or different research may use different levels to define what is positive. Some people might use 20, some a bit lower, but some use 25 or 30. So that's the first step, which is good news. So, and then you wait for a few weeks later, and if you start to see the heartbeat, that's one step further, which is called clinical pregnancy, when you start to see the heartbeat of the fetus or the baby in the womb, which is good news. Now, if you go further on, obviously, hopefully, pregnancy carries on very well, and at the end, there's a healthy baby. Well, actually, it's not definitely healthy. The term we use says live birth. So essentially what you define is a live baby being born usually after 23 or 24 weeks. So that's the term live birth. So those are the terms we use to define the success rate of fertility or IVF treatment. So if we look at them, so what is the best measurement? Obviously, the further we go, the better the measurement. So for example, if you talk about live birth, it is the best because it's gone through the furthest miles, like the further outcome. So, but sometimes it is hard to get the data as patients, come, who go to a fertility center to get treatment, and after that they move on to a different place, or they don't even report back to the center of what has happened. So it sometimes can be hard to trace live birth. Certain countries or states have a very robust system, a very good system to capture those patients if they haven't moved overseas. For example, in the UK, if you go through IVF treatment, then there's a system to report back to the central center to try to capture the outcome of live birth. Um, Now, but even that, most centers should be able to use clinical pregnancy to report at least their minimum standard to report their success rates. So I don't think in this day and age it's reasonable to use biochemical pregnancy to use as a measure of success rate, because not all biochemical pregnancies sadly results in a clinical pregnancy, i.e., sometimes with positive hormones, but after that the pregnancy can stop after that. Now the second question is how are we measuring them? So there are different denominator being used. For example, one of the commonly used method is per embryo transfer. So for each embryo transfer I do, it's counted as one. So if I do 10 embryo transfers, and let's say, look, just pick a number, 7 of them got pregnant, so success rate, you can say 70%. So so that's per embryo transfer. Now, there's a cleverer way of looking at it, which is called implantation rate. So, for example, not in Australia or the UK, we usually put one, maximum sometimes two embryos. But in certain countries, each embryo transfer, they can put 4 or 5 embryos back in, or 3 to 5. Um, there are risks, high risk involved in those pregnancies if you have like triplets or quadruplets or 4 or 5 babies, which is extremely high risk for moms and babies. But those are different topics, but this is the reason why in Australia we put 1 or 2. But to look at implantation rate, so if I put 2 embryos in one time, it's counted as twice. So it's the same as I put 1 embryo for 2 times. So it's a clever way of, avoiding many embryos being put in and counted as one, because if you put 2, it does have slightly higher success rate generally, with more risk being involved. So it's all about balancing the risk and benefit. So implantation rate is a clever way of taking into the number of embryos being transferred into consideration. Now there are pros and cons of looking at different ways. The other ways of looking at it is looking at per egg collection. So a patient's coming to fertility center, or even per starting, when you start fertility treatment. So patient starting on IVF treatment, starts taking the drugs and everything, has been counted as one. So I give you an example. For example, if I got 10 patients, doing IVF treatment. So if only 3 of them has got embryos to be transferred, the other 7, sadly, nothing to transfer after we collect the eggs, either no eggs or they don't fertilize or the embryos don't survive. So let's say ultimately only 3 have got embryos to transfer. So if I do 3 embryo transfers for 3 different patients, so if you look at my success rate per embryo transfer, let's say 3 of them got pregnant, all right? If you look at my success rate for embryo transfer is 100%, because 3 out of 3, they all got pregnant, 100%. But if you look at patients per egg collection, I got 10 patients coming to get egg collections. So the success rate per looking at all the patients starting in for egg collections, only 30%. So you can see there's a huge difference, 100% and 30% on how we calculate our success rate. And certain papers, for research purpose, would only look at fresh embryo transfer and ignoring their, because if you got fresh egg collections, you can have fresh embryo transfers. You can freeze the rest and, put back them later on. So you can either look at them as one treatment, or some research will look at them separately. So there are different ways of looking at it. Now, I'm going to talk about how bias can be introduced when you're looking at success rates. One of the commonest worry, or there are some centers who may do this worldwide, which I think should not happen, is to deny patients with reasonable success rate treatment, because that will affect their success rate. For example, in centers in the UK in the past has been accused on either say, look, patients with lower success rate being denied treatment, or some of them has got 2 centers. So they move their patients where they think has got a good success rate to center A, where the success rate will be very high, and they move the patients with lower success rate to center B, which has got a lower success rate. So for their branding, they always use the high success rate as their branding. So they get this 2-tier system. So and they have been accused of doing that in the past. Now, let's talk about league table. So there are pros and cons using success rate league table nationally or statewide. So let's look at the pros to start with. I'm going to talk about the cons later on. So the good things, certain centers do have better teams and better lab equipment, and thus they have a legitimate reason to have higher success rate. So they're actually doing a better job, so they have a higher success rate, which they should be to be given credit for. I always look at it as running a good F1 race, where you need to have good team, good tires, good car. So basically everything is good, then you have a good success rate. So centers sometimes, if you use league table, it can actually pinpoint and recognize centers with a below par standard, and it can be audited to, to improve, to look at what's wrong, to improve the quality of their service. And also, it is true the public can make use of reliable information to decide on their treatment before investing their time, effort, and money, or to choose a center to go to. Now let's go to the cons. The method in the calculation need to be standardized. I mean, there's a risk that different centers use different ways of reporting, as we looked at earlier on, and this can be really confusing. So we really need to have a very robust or very good legislation or way of controlling nationally or statewide, to make sure that the way of record is standardized, is the same, and there's a reliable method and also traceable method of record, so we know, look, things are done in a proper way. And the con side is what we mentioned earlier, like the patient selection. What I'm worried is patients with reasonable success rate being denied treatment because they just worried about their league table rather than focusing on the patients. Thirdly, success rate is not everything. What about other things may not be shown in the success, the league table, for example, patient satisfaction, emotional support, staff friendliness, professionalism of nurses and doctors, which are all very important. And also, league table doesn't show you the complications of treatment, which is rare, but if a center has got high league table but very high complications, then it may not show directly in the league table itself. So in a nutshell, I think, look, success rate is only one of the important factors to consider when you choose a center or decide whether to go on a treatment. And no, I don't agree that we should deny patients with a reasonable chance of success based on our league table. We should be patient focused and not league table focused. Thank you very much for your time.